She'll be talking to us about common allergy presentations in outpatient. And the whole point is we want it to be interactive, and would really appreciate you guys responding, whether you want to do that verbally or type it. That would be great. Just to remind everyone, please mute your mics, because it does cause some feedback, and also that we're recording the presentation itself. So Susie also is currently doing her allergy attachment in Royal London, and she also is doing her spin in allergy. And Susie has kindly agreed to be a point of contact if people want to talk to her about spin in allergy. We'll put her email address up later on if you'd like to email her. Super, Susie, go for it.
Okay, hello everyone. So this is just a presentation on sort of common allergy conditions that you may see either in A&E, or they often get referred to general clinics as well. So as Aine said, feel free to ask questions as we go along via the chat box, and I'll be asking some questions as well. So I'm just going to go through a few cases. So one's egg allergy, a case of nut allergy, and pollen food allergy syndrome. I'm going to introduce the eater's history as a way of thinking if a presentation is secondary to allergy, and discuss the advice that we should be giving to parents and patients, and just give a broad overview of the management of allergy. So the first case is a 9-month-old male called JF. He's eaten some scrambled egg, and 10 minutes after eating, he's developed hives, he's vomited, and the parents were extremely anxious and had rushed straight to A&E. And you're asked to review. So whenever there's obviously an acute allergic reaction, we always have to remember the ABCs of anaphylaxis. And so airway, obviously, cough, vocal changes, voice going hoarse, any sort of swallowing or swollen tongue, any sort of breathing difficulties, and C is also consciousness as well as circulation. So particularly younger children may be sort of clingy, or they'll have sudden behavioural changes sort of going quiet. So those are things to look at, as well as sort of signs of hypotension. So JF didn't have any symptoms of anaphylaxis, so we can all relax a bit and take our time to do an eater's history. So the eater's history is a mnemonic it's a method for the diagnosis of food allergies, and I've put a link to, I've just put underneath, it's taken from an Archives of Disease of Childhood article, and it's based on the principle that allergic reactions should have a relevant exposure to a known allergen, and the timing should fit. Certain environments are higher risk, and the symptoms should be, the signs and symptoms should fit with that of an allergic reaction, and they should be reproducible. And also thinking about risk factors, more likely if there are risk factors present. So exposure, so they either need to have eaten or handled the food, or sometimes if they're kissed or touched by someone who's just eaten that food. More rarely, if you fry foods, you can get aerosolization of allergens. And just thinking a bit more outside the box, animals, drugs, and venom also are allergens, so think about those as well. So it's usually going to be a common allergen, because it's quite rare to have an isolated, unusual allergen. So milk, eggs, nuts, soya, and wheat, all very common allergens in children. And prawns and shellfish allergy is more common in older children. So if it's a specific IgE type 1 mediated reaction, the timing is going to be sort of very rapid after exposure. So usually about 15 to 30 minutes. It can be delayed by up to an hour. That's unusual, and it's usually when the allergen is bound to sort of a fatty substance which delays its release. So for example, nuts in chocolate. And thinking about environments, so certain environments are more associated with allergic reactions. So weaning from breast or bottle milk onto solids can be a time of allergic reactions, but other than that, restaurants or takeaways are higher risk. People are eating foods that they don't necessarily normally eat, and there's a higher risk of contamination between foods. So they may be eating things that they don't even know that they've eaten. And as I said, it's reproducible symptoms. So if they've eaten it you know, since they've had this allergic reaction, then it's going to be unlikely that it's an allergic reaction if they've eaten it since and tolerated it. And the exception to this tends to be in infancy, when they may tolerate it on one occasion and then have a reaction on the next one. And then symptoms, I'm sure you all probably know: skin, if you get hives, swelling, redness; GI, vomiting, abdominal pain; respiratory symptoms may be cough, wheezing, runny nose, hoarseness and stridor. And neurological is in young children, maybe sort of clinginess, or they go quiet; other changes in behaviour, sleepiness or a feeling of doom; and obviously shock and collapse are cardiovascular symptoms. And then risk factors: it's much more likely to be an allergy if they have a personal history of atopy, or there's a family history of atopy in their immediate family. So these are the 14 most common food allergens in Europe, and all of these must be clearly labelled on all pre-packaged foods in Europe. But just warn parents, if they are travelling, that the labels are not as clear outside of Europe. So if we go back to JF and apply the eater's history. So he's definitely got exposure. He's eaten a few mouthfuls of scrambled egg. We know that egg is a common allergen. The reaction occurred within 10 minutes. It was in the home. He's not tried scrambled egg previously, but he had previously tolerated baked eggs in cakes and biscuits. And his symptoms were in keeping with allergy. He's got hives and he's vomited. And in terms of risk factors, there's a history of anaphylaxis to shellfish in a grandfather, but no other atopic history. So the story definitely fits with allergy. So do we need to do any investigations? Well, if you saw this child in A&E, you probably wouldn't do any investigations, but if you're an allergy clinic, you might do a skin prick test or a specific IgE to egg. But when you're seeing them acutely, then the main thing is management of symptoms. So you could give some antihistamines, and you need to really discharge the patient home with the correct advice for the parents. So in this case, we wouldn't give an adrenaline pen because he didn't have any sort of systemic symptoms, and egg allergy is less associated with airway narrowing as compared to nut allergy. But you still need to counsel all parents on the signs of serious allergic reaction, and make sure they know to call 999 and state anaphylaxis if they do think it's a serious allergic reaction. It's also a good idea to give them some written information, because we know that people don't remember what they're told when they see us, and they'll need a referral to allergy clinic, either via the GP or direct. So these are the allergy action plans, which all children should be discharged home with, and they're readily downloadable from, so I'm just going to take some water. So you can download them from the BSACI website. I'll put a link at the end on the resources. They're tailored to the individual, so you actually just write on the plan what their allergies are, their name, their date of birth, emergency contact details, and they've got all the signs of serious allergic reaction and a clear plan for parents in what to do. And if they do have an EpiPen or another kind of adrenaline pen, then there's different plans which are slightly different depending on which pen they've got, so they completely can be tailored to the patient. So what else are we going to tell the parents? We're going to tell them that it's a very common allergy. It usually presents in infancy. It's often after the first known exposure to egg, and urticaria and angioedema are both very common reaction, but severe reactions with airway narrowing are actually uncommon. And most egg allergy is outgrown, usually by school age. The more severe the reaction, it is associated with more persistence of the allergy. And the mainstay of treatment is just avoiding egg. But children can continue to eat baked egg if they have a clear history of tolerating baked egg previously. And well-cooked egg is often tolerated before loosely cooked egg. So these tables are actually really useful. So you can find them either on the BSACI guideline for egg allergy, or an Allergy UK has got good patient information leaflets which all have similar boxes to this, because it's not always clear to people what is a well-cooked egg, what is a loosely cooked egg, and what's raw egg. So we know that JF, I don't know if you can see my pointer, he tolerated cakes and biscuits that contained well-cooked eggs. So he could continue to eat anything in the sort of well-cooked yellow column. But he had a reaction to scrambled egg. And if you have a look at the orange column, you can see that boiled, fried, poached eggs, omelettes are all in the loosely cooked egg. So this patient would need to avoid anything in the loosely cooked egg and the raw egg category. And things that sometimes you might not think contain eggs, sort of royal icing can contain raw egg. Mayonnaise obviously contains raw egg, and fresh ice creams and fresh mousse can also contain raw egg, as well as things like Mars bars and Milky Ways, the soft centers. So things that people aren't always aware of. So that's always a good idea to kind of make your patients and parents aware of. And the other thing that causes a lot of confusion is what immunisations can patients have when they have an egg allergy. So there used to be concerns about the MMR vaccine, but it's now generally free of egg protein. So all patients who have egg allergy can have the MMR vaccine at 1 year old in primary care, unless they've had previous anaphylaxis to the MMR vaccine itself or a previous allergic reaction to MMR. So there's no increased risk of severe allergic reactions in children with egg allergy. So we can be very clear on that. And also the intranasal flu vaccine is safe to be given in primary care unless there is a history of anaphylaxis to egg. So that's also safe. The only one that's a bit more tricky is yellow fever vaccination. Obviously people are going to be doing less travelling at the moment, but it is contraindicated if they have a confirmed anaphylactic reaction to egg. But because of this, often primary care is not happy to give. And I think Evelina at the moment is the only allergy centre that's doing a special yellow fever vaccination clinic. So you may have to discuss with them. And all of this information can be found in the Green Book, which has all of our immunisation, sort of all the contraindications and the latest updates. Parents are also probably going to want to know, is my child going to have other food allergies? So the presence of any food allergy increases the risk of the child having another allergy. Egg allergy in particular is associated with peanut allergy. But there is evidence that in children with one food allergy, it's better, particularly in those of less than 1 year old, to introduce peanuts early, and that's associated with a lower risk of developing allergy overall. And the other question is, are they more likely to get asthma? So all children with food allergies have an increased risk of asthma, but obviously not all children are going to go on to develop it. So another question is often, I have another child who I haven't given egg to, should I delay introducing egg? And the short answer is no, you shouldn't. If you can get egg in early, it's much better. So the Department of Health recommends that eggs should be introduced from the weaning diet at 6 months. There's no evidence that delaying it beyond 6 months is going to reduce the chance of allergy. And there is evidence that earlier introduction before the age of 1 reduces the risk of egg allergy. So yes, they should definitely continue introducing egg around 6 months as per the sort of Department of Health guideline. This is taken from the BSACI early introduction guideline, and you can see it says if there is a risk factor for food allergy, such as eczema or existing food allergy, then obviously avoid the foods that you know your child is allergic to, but when they're ready, from 4 months onwards, introduce egg and peanut, followed by the other allergenic foods. And that's because there's evidence that reduces the risk of allergy. If they want some more general weaning advice, we would say try and introduce one new food at a time. You could wait 3 to 5 days between introducing foods, thinking of sort of non-immediate allergic reactions. Do a small amount of the food at a time in the morning when the child is well. And if there's uncontrolled eczema or asthma, just be aware that they're more likely to have an allergic reaction if they've got other things that are uncontrolled. Don't introduce when they've got a viral infection, because viral infections commonly cause urticaria and angioedema, and you might just muddy the picture and think you've got a food allergy. Not. And also infection does lower the threshold for allergic reactions. So it's best to do it on a day when the child is well. Prior to allergy clinic, just some good advice is just to take some photos of allergic reactions, because parents often don't remember what the rash looked like, so it's good to have a photo of the rash and take a note of what the suspected allergen is. So if it's a packet of crisps or a cereal bar, take a photo of it, make a note of the brand. And antihistamine should be stopped prior to clinic just for skin prick testing. So short-acting antihistamines 48 hours before, and long-acting 5 days prior to clinic if possible. So things like cetirizine would be 5 days before. But obviously they can continue any eczema and asthma medication. So allergy testing, just for people that don't know, we use a positive control, which is histamine, and then a negative control, which is saline. And then we have skin prick solutions, which contain the relevant allergen. A small blob of the solution is placed on the arm. We push a lancet through the liquid without drawing blood, and then we're going to read it after 15 minutes. If we don't have a skin prick solution, you can prick-to-prick test with the suspected allergen itself. And it basically, skin prick test means that there's IgE antibodies to the allergen. Those bind to mast cells in the skin, which causes the wheal, and this indicates sensitization. So the wheal size is related to the likelihood of allergy, but not the severity of allergy. And there's no cutoff for a positive test. So some centres use 3 millimeters and above, but we know that younger children may have smaller wheals. And the other thing to remember is that you can have sensitization without true allergy. So that's why it's really important to not just do lots of fishing tests for potential allergens, because you may just be finding that the child is sensitized but wouldn't have an allergy in the real life. So you may end up making things more complicated for yourself. So an interpretation should be always based alongside the clinical history. You can also do specific IgE blood tests, which again evaluate if there's any specific IgE to that antibody. But just remember, if you have a high total IgE, then your results may be spurious. So for example, in children with eczema, they frequently have raised specific IgEs to things which they're tolerating in real life. So they don't have true allergy. It's more a sensitization. But basically, the key message is that skin prick testing and specific IgEs both have their drawbacks. But any positive test of any level plus a history, you would say is an allergy. So JF does come back to allergy clinic, and he's avoided loosely cooked and raw egg. He's continued having well-cooked eggs, had no further reactions, and you can see he's had some skin prick tests which are positive to egg extract and to egg and to raw egg. So the plan is just to continue eating baked egg and to avoid loosely cooked and raw egg. And we would follow him up over time to see, and we would see if the skin prick testing had smaller wheals. And if the wheals were going down, that may indicate that he's growing out of his allergy, and in which case we would book a hospital-based food challenge. So food challenge is sort of the gold standard test for diagnosis or to determine if the child is now tolerant to that food, so no longer allergic. So it needs to be a food that the child will eat, because if you bring them into your day assessment unit and they're not going to eat any cakes or biscuits or scrambled egg, then there's no point. And you need to give them incremental doses of the allergen. They're given over time. So you can see the first dose is sort of less than a gram, and the final dose is 21 grams. So again, just be realistic about how much an infant is going to be able to eat. And you observe for 2 hours after you've given the dose, and then you send the child home with a clear plan of, yes, they can now tolerate all loosely cooked egg, or no, they can't. But just bear in mind that they can be equivocal if the child is sort of having some subjective symptoms. So if they get maybe a little bit itchy, or they say they're just feeling a little bit funny, then you may get a sort of, you may not be able to tell whether they truly passed the test or not. Always perform it on a day when the child is well, because if you have uncontrolled asthma or eczema, then you're more likely to have a severe allergic reaction. Make sure you stop their antihistamines prior, and you have to counsel all parents that yes, you are giving an allergen, so there will always be a risk of a reaction, including anaphylaxis. So they have to be performed in an area with resuscitation facilities available. And you need to keep eating that food. So often people want to know if they can eat a food and then they never eat it ever again. But in order to maintain tolerance, you need to be regularly eating it. And we do say 2 or 3 times a week, because if you abstain for it for a long period of time, then it can be associated with a re-emergence of allergy. So only really perform a food challenge if they actually want to eat that food regularly. So this is just a case summary. So egg allergy is usually outgrown in childhood. We follow the skin prick test pattern to see if there's a trend towards tolerance, and we may introduce the food by a hospital-based food challenge, or sometimes we do home reintroduction. It just depends on their actions. So is there any questions on egg allergy or anything that's not clear in my talk? I'll just have a look on the chat.
There's one on there, Susie, from Heba. So is the allergic reaction during food challenge IgE mediated or cell mediated?
Okay. So we're testing for IgE mediated allergic reactions because there's no real, you can FPIES challenges, which are obviously non-IgE, but otherwise we don't tend to do challenges in hospital for non-IgE mediated allergic reactions. They're just a bit more difficult because the symptoms could potentially, you know, show days later. So if we think it's a non-IgE allergy, then they tend to have the egg introduction ladder and they would do that at home. And that's, yeah, but I think it's the BSACI has got sort of the egg introduction sort of ladders as well as the milk ladders. So I hope that answers the question.
Yeah, and usually you keep them in for a shorter period of time where you'd expect an immediate reaction. Okay, so are there any other questions?
Any other questions, or I'll just move on? So the next case is a nut allergy. So it's a 2-year-old boy. He's been seen in clinic and he's been referred for having a suspected nut allergy after having 2 immediate reactions to nuts. So if we go back to our eater's history, so he's eaten a sweet containing nuts, so we've got exposure. We know that nuts are a common allergen, and the symptoms occurred almost immediately, so the timing fits. And the environments, they were higher risk. He was at a friend's house and at an airport. The symptoms were reproducible because he'd not eaten nuts previously and he's had now 2 reactions to nuts. And the symptoms, he had erythema and hives, he vomited, and he started clearing his throat a lot and coughing. And he also became quite distressed and was a bit clingy, and he was sitting on mum's laps. So if people could just put in the chat, what do you think about these symptoms? Would we be worried, or how serious is this reaction, do people think? So I'll just give people a few minutes just to think about that. Yeah, so everyone's sort of, they've got it straight away. So yeah, so it is anaphylaxis, isn't it? Because you've got the ABCs here and he's definitely got symptoms. So this is anaphylaxis, and the symptoms did resolve within 30 minutes. And actually that's quite a common presentation to our allergy clinic, is anaphylaxis that was given no treatment but has resolved. But obviously you're not going to send them home with just hoping that will happen next time. So in terms of risk factors, there's a mother with hay fever and a sibling with egg allergy. So we would just take a full history and just find out if there's anything else that he's excluding, or whether he's tolerating sort of the main other allergens, which he is, but he's never had nuts or sesame previously. So we always ask about, particularly because this one we don't know which nut he's eaten, always ask about lentils, chickpeas, peas and beans, because they're legumes, and peanut allergy can be found is a legume allergy, and so there may be other allergies including to lentils, chickpeas, peas and beans. And the other group of nuts is tree nuts, which is basically every other nut. So I've just grouped the two together. So walnuts and pecan and cashew and pistachio are often found coexisting because the proteins are quite similar. And then the rest of the nuts are just, they're all under the tree nut bracket. So he had some investigations, and they were kind of a bit of a mixed bag. So we had a 4mm wheel to peanuts, almond and Brazil were negative, cashew was 4, hazelnut was negative, pecan was 6, pistachio was 3, walnut was negative, and sesame was 13. So if we just review the case, overall he has a good varied diet, but it was a very severe reaction and we don't know which nut it was to, and we think it was that he had anaphylaxis. He had a positive skin prick test to cashew, pecan and pistachio and sesame. So what are we going to advise for the parents? So just people want to just have a quick think about, are you going to tell him to avoid all nuts, or can he eat some nuts? And what about sesame? I'll give people a couple of minutes. So, yeah, so most people have gone for avoid all nuts, and this takes me to my point that, again, that allergy testing is not perfect, and we're not going to be that confident in our allergy testing that we're going to base all of our management around it. We know that peanut and tree nut allergy frequently coexist, and if you have one nut allergy, you're more likely to have a second nut allergy, and it may be a nut that you've not eaten or you've not eaten for a long time. The BSACI guidelines for nut allergy sort of state that an 8mm wheel to peanut or cashew, hazelnut or walnut is highly predictive of allergy. So his levels, according to that guideline, would be sort of indeterminate, but he's had such a severe reaction that obviously we would still be worried. And the same for specific IgE blood tests, they're not always very reliable either. So hazelnut, even if you have a high specific IgE to hazelnut, it's still not very accurate. And walnut is quite sensitive if it's positive, but it's missing lots of people as well. So again, you can't really trust it. So the options are, and as we've said, any history of nut reaction with any positive test is an allergy. So sometimes we do specific IgE blood tests as well as a skin prick test to see if we can get some more information. And he was offered those blood tests, but sadly was not able to tolerate them. So the options were avoid all nuts and sesame, or could you think about doing a food challenge to some of the nuts that he was negative to on skin prick tests. But because we've only got one result and his reaction was quite severe, the family and us decided that it's better just to avoid all nuts and sesame. So like before, give them the education, give them an allergy action plan and prescribe EpiPen or Jex. So Emerade is still off. We're still not using Emerade in our allergy service because of the concerns of safety. And there's also been problems with national shortages. So it's been very difficult to get hold of pens. And because of that, instead of having 2 pens which are just left at school, you may need to tell parents that they have to drop off the pens at school and pick them up afterwards, because they may only be able to get 2 pens each. And this is just to highlight the doses of EpiPen and Jex are down to weight. So for EpiPen, once you get above 25 kilos, you have 300 micrograms. And for Jex, once you get above 30 kilograms. And for EpiPen and Jex, the 300 micrograms is the adult dose. So there's no 500 micrograms of Jex. But obviously, if you were in A&E resus and someone 12 years and above came in, you would use the 500 microgram dose of adrenaline, but you just have to draw it up. And I thought we could all, because there's a lot of problems. Apparently only 21% of healthcare professionals can correctly use an EpiPen. So I thought we could just have a look at this video just to remind ourselves. Just let me know if it's not working properly.
EpiPen Junior work in exactly the same way. You can watch this video, which details the correct administration technique. The EpiPen is clearly color-coded for easy identification and administration during an emergency. The safety release cap is blue and the needle shield is orange. The easy way to remember this is blue to the sky and orange to the thigh. Someone experiencing anaphylaxis should be placed in a comfortable position. Most people will lie flat. People having breathing difficulties should sit up. Pregnant women should lie on their left side, and people who are unconscious should be placed in the recovery position. To remove your EpiPen from the carry case, flip open the cap and slide the EpiPen out into your dominant hand. Keep your fingers and thumb away from the orange shield as this contains the needle. With the orange shield facing down, pull off the blue safety release. Holding the thigh still and with the EpiPen auto-injector about 10 centimeters away from the thigh, with the orange tip pointing towards the thigh at a right angle, jab the EpiPen onto the thigh and hold in place for a full 3 seconds. A clicking sound will indicate that the device has been activated as it is spring-loaded. You don't need to remove clothing, but avoid putting the needle through seams, buckles, or zips. When administering the EpiPen to a child, ensure the child's thigh is held still to avoid the chance of local tissue injury. After administering the EpiPen, you or someone with you should call 999 immediately, even if symptoms are improved.
So that's just a reminder to everyone of how to correctly use the EpiPen, and Jex has similar sort of online videos as well. So just in conclusion, nut allergy again is quite common, affects 2% of children. Most children are diagnosed in the first 5 years of life, often on first known ingestion. So infants with egg allergy and severe eczema have a higher risk of peanut allergy. So those patients, it's really important that if we're seeing them before the age of 1, the early introduction of peanut to higher risk infants is associated with a lower risk of peanut allergy overall. And use the BSACI early introduction guideline, because that just tells you how to start introducing nuts and egg. Nut allergy is more likely to be long-lived. I think it's about only 20% of people outgrow a peanut allergy. And yeah, don't fully trust the test. Any history of nut reaction and any sort of positive test is going to be an allergy. If the tests don't match, then you're obviously still going to have a careful think about, could this still be allergy and what else is going on? So does anyone have any questions? Oh, sorry. And because it's more likely to be lifelong, they need regular retraining in the use of the adrenaline auto-injector. I don't know if people have heard, there's been lots of sad cases recently, particularly teenagers who have anaphylaxis and they don't use the pen or they don't have it on them. So particularly with your teenagers who are getting more independence and they're going to be not having the mum or the dad there to carry the EpiPens, make sure that they know how to use their adrenaline auto-injector. Think about if they have uncontrolled asthma, they're more likely to have a severe reaction. So it's really important we control their asthma. Any sort of previous severe reactions indicates that they may be at risk of severe reactions, and illness, alcohol and exercise also increases your risk. So make sure you discuss those things with your patients, particularly older patients. Does anyone have any questions about nut allergies or anything that's come up in that case?
So there are a couple of questions. So the first question, Susie, was from the previous case from Hiba, which I think you have, well, has been answered already, but I just wanted to put it forward again, just so Hiba can let us know if it's been answered. So can you rely on skin prick testing only, was the question earlier.
So there's different practice in different allergy centres, so there's no sort of complete consensus. So the short answer is probably no, because it is, again, operator dependent. Did they definitely put the right solution on? Did they definitely do it correct? So for example, the situation where we wouldn't completely trust them is where you've got some tree nuts positive and some negative. Most of the places that I've worked wouldn't be happy to say, okay, introduce the ones that were negative at home without sort of further testing. So I know UCH, they tend to do, in that kind of case, they do specific IgE as well. And then if that, and then combining those they would use to elicit the overall sort of whether we think they're going to be likely to be allergic or not, if that makes sense. So I think I started waffling then. So generally, or sorry, Susie. Yeah, or you may decide to do another skin prick test further down the line and compare them. So, but generally, in the places that I've worked, I don't know, Aine, if you've had different experiences, just one piece of information alone, you would be a bit skeptical, particularly in this case where you don't know what the nut was. You might feel more confident if you knew exactly what you thought they'd reacted to.
Yeah, and yeah, completely agree. History is key. Targeted focus history alongside reported symptoms, alongside testing and reproducibility. So if you keep getting the same reaction with a positive testing, then that will increase your likelihood of having an allergy. I hope that answers your question, Hiba. And I think that's another one from Roseanne about how long do you have to observe a child in A&E after they have used an EpiPen, if they are well after the use of an EpiPen?
Yeah, so I think so that's probably more related to anaphylaxis, which is going to come up tomorrow in tomorrow's talk from Paul Turner. But generally sort of 6 to 8 hours is the normal sort of guideline. And that's because most of, if there is going to be, biphasic anaphylaxis reaction is quite rare, and usually it would be within that time frame. So usually it's 6 to 8 hours afterwards. I think
there will be exactly as what Susie has said, but there's obviously local protocols that you'd have to follow, local guidelines, and also just to signpost, there's an excellent resource on pediatric foam about biphasic reaction, which is also linked in the learning pack.
Okay, so I think I'll move on to the next case now. So this one is a 9-year-old female. She's been referred to allergy clinic, and there was a concern about a food allergy to kiwi. So just going back to the eater's history, she's eaten a kiwi. Once it was an actual kiwi, and once she ate a cake which was on a plate next to some kiwi slices. So kiwi is not one of our more usual allergens, but the reaction did occur within sort of 15 minutes. And she ate the kiwi at home, and another time it was at afternoon tea whilst out. And in terms of reproducibility, she's had 2 allergic reactions. And she also tells you she has similar reactions to raw apples, but she eats apple crumble. And she has similar reactions to melon, but she's tolerating raspberries, blueberries, oranges, and grapes. So what do people think about that as a presentation? What diagnosis are you thinking? Everyone's resting their fingers. So a few people have replied, so it's oral allergy syndrome. So this is just basically, that's just the rest of her history. So oral allergy syndrome or pollen food syndrome, it's due to pollen sensitization and a cross-reactivity between proteins in birch, tree, grass or weed pollen and similar proteins, the PR10 protein, which is found in some fruits, vegetables and nuts. It's a hypersensitivity reaction. So for example, birch pollen cross-reacts with apple, peach, cherry and hazelnut. And apple is probably the most common one that we see. Usually it's older children, and they usually have a history of hay fever, but not always. So the diagnosis can be made clinically, so you don't have to do any allergy testing. So if they've got classic hay fever symptoms, sort of May to March, and they're reacting to fruits, vegetables or nuts, and they're having reactions to raw foods but not cooked fruits, or perhaps when they're peeling fruits or vegetables they're getting reactions, then that's sort of the classic symptoms if they occur on biting, chewing or swallowing, and if it's sort of a rapid reaction. And it has usual symptoms of mild to moderate tingling, itchingness, soreness, and sometimes a little bit of swelling as well, so a bit of angioedema. So this is just the Royal Brompton's guideline for how to diagnose clinically, and it basically says if you're having a reaction to raw food or when you're peeling foods and you've got a history of hay fever, then yes, you've got pollen food allergy syndrome. So she did have some skin prick testing, which you can see is sort of mildly positive to kiwi and apple, and she's also sensitized to birch and grass pollen. And she was also sensitized to cats and horses, and she did have a history of, again, of allergies to animals. So the Allergy UK website has got a really useful patient information leaflet, and this table's taken from there, and it just shows you which foods are commonly associated and which are less common. You can see apple, peach, pear and plum are sort of the most common fruits. And the management is just going to be avoiding those fruits. They can often tolerate peeled, cooked or tinned versions. If they do happen to have a reaction, then they can just take some antihistamine and drink lots of water. So you obviously do still have to counsel all patients on the signs of serious allergic reaction, but typically people with pollen food allergy syndrome shouldn't have severe reactions. We do always say avoid the sort of those lovely fresh juices where they have, you know, the celery and 5 other fruits, or smoothies when you're out and about, because they contain a really high protein load of lots of different fruits. There's a high risk of contamination as well, because lots of fruits are sort of being made there. So those can be associated with more serious reactions. So they can make smoothies and things at home with fruits that they know they're not allergic to, but avoid them when they're out. And it's the same if you've got pollen food allergy syndrome to soya, then obviously you need to make sure you're avoiding soya drinks, because again, that's a really high protein load, and you can have a more serious reaction. So again, do they need to be seen in an allergy clinic? Not, but consider referral if they're reacting to cooked versions of the food, or if they're having severe symptoms, because they're going to need adrenaline if they're having severe symptoms, and it's not common, so you should be thinking, is this actually pollen food allergy syndrome, or is it a primary food allergy? And again, if they're reacting to nuts and you're not sure, is it a primary food allergy or not? And obviously the other important thing in management is make sure you manage their allergic rhinitis. So allergic rhinitis is really common, and it can really affect people's sleep and school performance, and can have really dramatic impact on families' life. And it also makes asthma symptoms worse, because the role of the nose is obviously to filter and to air it. So it's and you're more likely to be hospitalised with asthma if your allergic rhinitis is not well. We always examine patients just to check your diagnosis. Is it definitely allergic rhinitis? Ways when there is a story of a blocked nose, check for structural defects. Look, you know, there is a potential for tumours. Make sure you're thinking of that. Otherwise, just looking for signs of allergy.
Sorry, Susie. So I think CW, just if you could mute yourself, just because it's causing a bit of interference. Thank you so much.
So this is the ARIA classification of allergic rhinitis. So ARIA is just allergic rhinitis in animals. And the key message from this is it's moderate to severe if it's disturbing sleep, it's impacting on activities, impairing work or schoolwork, and that's when we really need to step up our treatment. So this is quite a busy slide, so you probably won't be able to read all of it, but I'm going to be going through some of the steps. This is the South East London Integrated Guidelines for the management of allergic rhinitis, and I put the link at the end to this. So if your symptoms are sort of moderate to severe, you're going to start step 1 and step 2 to begin with. So step 1 is just sort of the conservative advice that we can give. So it seems really simple, but often patients don't think about it. But don't dry your clothes outside, because they'll be all covered in pollen. And if you're indoors, try and keep the windows shut, especially early morning when the pollen is rising, and then in the evening the pollen is falling again, so the counts are highest then. So it's a good idea to shut the windows then. And if you just walked your dog or gone to the park, then having a shower and changing your clothes when you come in can make a real difference, just washing all that pollen off you, or at least washing your face. And Nasal saline sprays can be really useful, and they're recommended like 2 or 3 times a day, just to kind of just washing out the pollen really. So as I said, if it's moderate to severe then symptoms, then you're going to be starting step 1 and step 2 at the same time. So step 2 is either a daily antihistamine or a nasal spray, depending on where their symptoms are predominant. So if they're having loads of nasal symptoms, you may just start the nasal spray first. Most of the patients we see in clinic are getting quite significant symptoms, and we end up starting the conservative, the nasal spray, and the antihistamine all at the same time. So try and use a non-sedating daily antihistamine. So cetirizine is normally our go-to because it's non-drowsy and it's longer lasting. But if cetirizine and loratadine fail, then you can use fexofenadine. That's licensed from 6 years up. And then you use a nasal spray. So we tend to use Avamys because it's good for the eye symptoms as well, but there's other ones that you can use. So for example, Flixenase is licensed for 4 years. So if you have a younger patient, that might be a good one to start with. So, and if all of that is not working, then you can change them to Dymista nasal spray, which has an antihistamine and a nasal steroid in. And that's really good for asthmatics as well. If they're having eye symptoms, we tend to use olopatadine drops. So you can just use 1 drop in each eye twice a day. We used to use sodium chromoglycate, but I think that's more irritant. So I think patients tend to prefer olopatadine. And if it doesn't work, then check that they're actually using, because no one's using the nasal spray correctly. Unfortunately, there's a really nice video on this Itchy Sneezy Wheezy website, but the website's been down for a few days, so we can't see it today. But basically, you have to use your left hand to insert it in your right nostril and use your right hand to insert it into your left nostril. So some people say it's like a ninja. I don't know enough about ninjas to know why this is a ninja thing. And that's so you're getting more of the side of the nose, because if you put it straight up, then you're just going to swallow it all and it's going to do nothing, because it's just, you're just eating it instead. If the nose is completely blocked, what we do in our service is you could use a short course of decongestion, or you can use some steroid nasal drops. So we often do about 6 weeks of nasal steroid drops to open up the airway, and then use the nasal spray. Because if it's completely blocked, you're not going to get your steroid to where you need it to be. So it's a good idea to do one of those 2 things. If they have symptoms all year round, so if they say to you, I've got hay fever, but actually I have it all year round, so I think it might be a bit worse in winter, then it's probably that they're actually allergic to house dust mites, not pollen. And there's a good patient information leaflet, which again, I've got the link to at the end. And there's a link in the learning pack as well. And that's just some advice for the patients on how to reduce house dust mite burden. So who are you going to refer? So if you've optimized all of their treatment and it's not working, then you can definitely discuss or refer to an allergy centre. Sometimes we use Montelukast. With Montelukast, they're either going to respond or not respond, but just make sure you counsel parents the possibility of sleep disturbance, nightmares, or vivid dreams. And there have been more recent concerns about effects on mood. And then refer them to allergy clinic, because we could consider doing immunotherapy. So immunotherapy is only available in the NHS for the failure of medical therapy. And the idea is that you're desensitizing the immune system so that it does not respond when challenged with the allergen. So we do either sublingual or subcut. At the moment in our service, we're only really doing it if there's one main allergen. So for example, grass pollen, or birch, or house dust mite. Other centres may be doing slightly different. And you just start it before the season, but it can be quite, so say for example, the Grazac sublingual one, the patient will have to take it every day for 3 years. So it does take quite a huge commitment. They have a few doses in hospital, they update in hospital, they're observed to check they don't have a serious allergic reaction, and then they have to take it every day. And then you normally see them sort of either once a year or a couple of times a year to check how they're going, check compliance, and check that it's sort of what their symptom response has been. So it's only really suitable for patients that are motivated to do it. And obviously, if it's house dust mite and it's year round, you can start that at any time of year. So that's what's available at the moment. So again, in conclusion, history is the most important. Avoid doing screening tests for potential allergens, because you're likely just to get a confusing picture. All patients with a new allergy, please give them an allergy action plan, which as said can be downloaded from the BSACI website. And if they're given an adrenaline pen, they must be trained on how to use it. There's no evidence for delaying the introduction of allergens when weaning. An early introduction of egg and peanut is associated with reduced risk of allergy. And the BSACI have got this nice early introduction guide, which tells you about who's at higher risk and when to introduce foods. These are all the resources, so I'll just leave it there for a moment, but I guess this is all going online. Most of these are actually also in our learning pack, so. And I've also been asked to display this, and it's just Imperial, do allergy PG certificates, PG diplomas and masters. And at the moment they do also have some scholarships, but the deadline is sort of the 15th of July. So please do take the details and get in touch if that's something that you would be interested in. Does anyone have any questions?
Thank you so much, Susie. So there were a few questions. One of them was about exercise and its role with regards to severe reactions, anaphylaxis. And I've attached a paper on there just because it's not a very straightforward answer. There's a particular area on exercise there, so worth reading up on. I don't know, Susie, if you want to comment on that.
Yeah, no, I think Paul Turner tomorrow will probably be discussing it, and yeah, you're right, it's not a straightforward answer. So yeah, I think.
There's another question from Heba that again is not a very straightforward answer about sort of swinging reactions. So I'm assuming, Heba, what you mean is sometimes reacting and sometimes not reacting, which I suspect has to do with the amount of food that's been ingested, which again is more sort of specialty allergy referral and discussion with family. But Susie, I'll let you comment.
Yeah, so yeah, that's a difficult one because yeah, you're right, there are cases. So yeah, everyone has a set dose point in terms of what will cause an allergic reaction, and we do get people who are having food challenges that, you know, will tolerate half of it, but then once they go on to the higher doses, they don't. But yeah, the point at which they would react may be different on different days as well. So it is quite difficult, and that'd definitely be one that we would sort of be discussing. So I don't that's really to add on that.
And Adeep had a question about what's defined as failure of therapy to make someone a candidate for desensitization, I'm assuming with immunotherapy.
Yeah, so basically, if they're on sort of a daily antihistamine, conservative advice and a nasal spray, then that's the point we would consider immunotherapy. I don't know if other centres have a sort of more stringent, because strictly speaking, you could also then go to Dymista and Montelukast, but we often don't try Montelukast, we often go straight to immunotherapy if there's sort of one predominant allergen. Do you do differently?
Yeah, I think that's generally it. And also I think there's no harm if you think that they are a candidate for referral, and then the centre that receives the referral can then have another consultation and have a discussion, because as Susie has rightfully pointed out, it's a commitment, a long-term commitment. So it is a conversation that needs to be had again and again.
And also, just in terms of timing wise, by the time we've seen them, we need to arrange, and we need to start it before the season. So we would often, so if it's birch, we're going to be starting in sort of December time. So it's better that we have them earlier so that we can have that conversation and get ourselves organised to start it earlier. Otherwise, they've missed that opportunity for that whole year. So that's the other thing to consider.
Are there any other questions? Susie, I'm aware that I was meant to give you a 15-minute reminder, but your timing is so spot on that I didn't.
Okay. I was thinking that I hadn't had it, and I was like, well, I must be running on time today.
Was that another question from Adi? Amazing. Okay.
No, it was just a comment. Sorry, just to say that that was really helpful. Thanks, Susie. Thanks very much.
Oh, thank you. This is I'm just paying these people to make these comments.
Great. So I have I have put up the learning pack link as well as the survey link, and I know we keep putting it up, but it is really useful for us to know how you have found the session, and of course really useful for feedback for the LSP as well as for the speaker themselves. And a lot of the issues or questions or discussions that we've had over the last 3 sessions are all addressed in the learning pack. So please use them. There are lots of links on there that you'll be able to then keep. And when they get updated, it'll be updated because it's a direct link. So thank you so much, Susie. Atta's on here as well. Great work. If there are any questions about Finn or for today's presentation, I'm sure Susie's happy to be emailed as well.